following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, prescription drug abuse. Two experts are here to answer your questions. Now here's your host, Dr. Joe Prudhomme.
Good evening. West Virginia has a drug problem, and it's not crack or heroin or even alcohol that's causing the most trouble. It's prescription drugs, primarily opioid and narcotics, used for pain. In fact, according to the Centers for Disease Control, deaths resulting from drug overdose in West Virginia rose 550% in the 5 years from 1999 to 2004. And it's no better today. How can we stop this tragedy? What are the signs that you or someone you care about are becoming addicted? Where can you go for help? We'll get the answers to those questions and more tonight from our two guests, Dr. Rick Vaglienti, Director of the WVU Pain Clinic, and Dr. James Berry, an addictions expert at WVU Hospital's Chestnut Ridge Center. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. Jim, many experts say we've got an epidemic in West Virginia, and I understand that the legislature has a bunch of new laws that they're considering this session. Can you tell us a little bit about the magnitude of the problem?
Yeah, I would agree that it is an absolute epidemic. It seems like about 10 years ago, we were treating mostly alcoholics in our services. And within the last 10 years, it seems like 50, 60, 70% of the patients that we're treating now we're treating for addiction because of prescription pain pills.
Interesting. Rick, I'm a doctor that can prescribe pain medicine. Your specialty deals with pain. What's your perspective on these issues?
Well, my big concern is to make sure that the people that need treatment get treatment, and that those people who want the medication for illicit purposes don't get the medication or have difficulty getting it. And so that's sort of where I lie in this argument.
That must be a pretty hard decision sometimes. I mean, to know what people's underlying motivations are. What kind of process do people go through when they come to see you to make sure that their need is legitimate and that the drugs are not abused?
Well, over the years of practicing pain medicine, we've come up with a system where you're required to have a psychological evaluation to make sure that you don't have addictive tendencies. But more importantly in my profession, to make sure you don't have an underlying anxiety or depression that you're treating incorrectly with pain medicine, because they'll make you feel better. And then you have to sign some papers, and you have to submit to random urine drug screens. And if you do all that, then we live happily ever after, so to speak.
It's kind of hard, though. I mean, as a doctor, some doctors seem to overtreat, some undertreat. Do you know anything about the bills that are in front of the legislature this year? Or did they address some of those issues about over or under treatment?
Yeah, I don't know much about the bills right now, but of course it has been a difficult issue, and I can definitely appreciate the problems that somebody like Rick has, who's trying to treat pain and at the same time trying to keep people from putting themselves in greater danger because of the medicines they've been prescribed. And certainly it's a balancing act, and many of the things that he's talked about, those are great things to be doing.
I worry about my patients who are taking pain medicine acutely because of surgery and always warn them to be careful and don't drive or do anything dangerous. That's different than chronic pain, right? When somebody gets on a maintenance dose, a steady dose of narcotics, they're not nearly as likely to hurt themselves or somebody else doing something like that, are they?
Yeah, they become tolerant to a lot of the side effects, but in this day and age, unfortunately, you still have to warn them of all that in order to protect yourself as a physician. You're looking at medical legal issues, you're looking at sanctions from the Board of Medicine, you're looking at violation of federal laws and possible arrest and prison time. And those federal agents, when they come into your office, they don't have a great sense of humor. So you want to try to be as straight and narrow as possible.
And you certainly don't want to hurt anybody either. I mean, West Virginia as a whole, and southern West Virginia in particular, has one of the biggest drug addiction problems in the whole United States, I understand. And so we're all the time reading about somebody overdosing. And I mean, that weighs heavy on your mind if you think that the drugs that you're given are being diverted and somebody dies because of it. How can we help people who might have become addicted and want to undo that?
Sure. Let me just say that West Virginia leads the nation now in number of overdose deaths. And many of the counties are being affected, but especially these southeastern counties. And, getting people into treatment early is important. Learning to recognize, teaching physicians on how to recognize the problems. If somebody's become dependent on the medication to the degree that they've become an addict, then treatment early.
Okay. I understand we have a caller on the line, Betty from Cabell County. Betty, ask us your question, please.
Yes, I currently take Ultram for psoriatic arthritis, and I've been on it for quite some time. And I was just wondering if any new laws that are being proposed would affect the availability of this drug for people like myself.
Okay, Betty's concerned about the availability of Ultram, and I think one of the laws does concern Ultram or tramadol, changing the schedule of that. Isn't that right, to a Schedule 4 narcotic, which would be a low level, but
That's what I understand. How it would affect Betty's availability to get the medication, I'm not sure right now.
Betty, that would be the lowest level on the narcotics hierarchy. That would be like one of the mildest pain medicines, but it would become a scheduled drug so that the doctor would have to write his DEA number on the prescription, and it would be considered a controlled substance. It shouldn't make it hard for you to get, and it shouldn't make it more expensive, but it does mean that they're just going to be a little bit more restrictive about who they give it to. And as long as you've been doing well on it, I can't imagine that would affect you getting that medicine.
Agree.
All right. Well, teach us a little bit more about how to walk this tightrope. I'm a surgeon. I don't do chronic pain management like you. Help us understand how we can walk that line about not undertreating and not overtreating pain.
Well, you have to use general standard of practice. That's like anything else in what's right in your region. For example, you do hand surgery. Implanting a tree limb in someone's arm to replace their humerus is not standard of practice. And so if you're outside the standard of practice, you should be concerned. The other issue is to watch for increased escalation of usage. If it seems unreasonable, and a lot of times I'll double the dose of a pain medicine of a patient who complains of poor control. And if doubling the dose doesn't do anything for that patient, then you've got to be concerned that they're either tolerant or they're using it improperly or treating an anxiety or depressive disorder that's not diagnosed. So it's just a wary eye.
Wary eye. We've got another call from Steve in Putnam County. Steve, ask us your question, please.
Hi there. I woke up about 6 months ago all of a sudden, and my hands were hurting. I can't close my hands anymore. And I went to a doctor, a rheumatologist, and I'm in the process of getting tested for this. What I'm afraid of is getting pain medication that would become addictive over time. My hands feel like they're broken. There's pain all the time now. And I was wondering if there are drugs that are not addictive.
Sure. Jim, you want to take that one?
Yeah, sure. There are a number of medications that are not addictive that we're used to treat pain, and certainly Rick would be able to tell you more about that. There's some antidepressants that are available that actually help pain, some anti-epileptic medications that help pain. And I think it sounds like your biggest concern is just worrying about becoming dependent on a medication if somebody were to prescribe it to you. And a couple of things that the doctor should ask you to help nail that down is if there's addiction in your family, if you've had previous problems with addiction before, if you've got a problem with alcohol. these are all indicators that maybe chronic opiate pain medication may not be the best for him.
Interesting. We've got a call from Tony in Harrison County. Tony, ask us your question, please.
Yeah, I've been on the controlled substances for a long time. I mean, like several years, 3 or 4 years. I take the morphine I was taking at 60 milligrams 4 times a day, and I was taking oxycodone at the same levels. Now I'm on the morphine at a maintenance level, 130 milligram once a day, and hydrocodone 1 tablet 4 times a day. But I'm concerned using the acetaminophen in between all of that. I'm worried about damage to my liver.
All right.
That's a reasonable concern. I mean, really in the United States, Tylenol is almost in everything we take, and you have to stay under the roughly 4 grams a day. If you stay under 4,000 milligrams or 4 grams, that's supposed to be safer than going over, and use of alcohol with Tylenol, even in small amounts, is discouraged. And there are other medications that have the same pain medication you're taking in them without the Tylenol. It just might cost you a little more money.
Okay. Very interesting. And I heard recently, I mean, they warned us as surgeons that a lot of people can't even tolerate the 4 grams a day and advise us to back off to 3 grams or even less. And if somebody has any liver dysfunction at all, just to avoid it altogether. Is that your
unknown.
practice too?
Yeah, it's unknown. It's just, we don't know yet.
Got it. So when somebody comes to see you and you run a pain clinic, do you start off with non-narcotic medicines usually, or do you start directly with narcotics? How do you decide what medicine is appropriate for what patient?
No, we use narcotics or opioids as later last resort. We're an interventional type pain clinic, so if there's some kind of intervention that is injection or surgery that will alleviate the pain, we do it first because there are less problems with it and it gives you better pain relief. And then we go through a hierarchy of medications. You might have non-steroidal anti-inflammatories. As Jim has said, we use a lot of antidepressants. There are many good antidepressants out there in the SNRI family that are great for pain. We use anticonvulsants a lot, particularly gabapentin and pregabalin. And then if we have to, we go to low-dose pain medication. And then if we have to, for treatment failures, we move up to things like morphine and fentanyl and oxycodone if needed.
So those are the last resort. Interesting. We have another call. Betty from Lawrence County, Ohio. Ask us your question, please, Betty.
I take Percocet every 4 hours. I'll be 75 tomorrow, and I have arthritis from head to toe. And I take it every 4 hours, but I don't get a whole lot of relief from it anymore. Is there anything that would do better or would help me more?
Well, happy birthday, Betty. Let's
Thank
give
you.
that to Rick. Rick, what would you suggest Betty look into?
Yeah, it sounds like a tolerance issue, and you either have to change the dosage or change the medication to try to get some cross-tolerance activity, and that's what I would do. I'd recommend. But you get in a situation where the family doctor might not be comfortable doing that, and so maybe a consultation with either Jim or someone like me to say, is it safe to go to the next level with this lady despite the fact she's 75? You still have the dependence and withdrawal issue no matter what the age.
So she should first let her family doctor know and see if he feels comfortable to take it to the next level. And if he doesn't, then perhaps see somebody like you.
A consultation, yes.
Perfect. We have Patty on the line from Raleigh County. Ask us your question, please, Patty.
Hi, I have a son that's been on pain medicine probably for about 3 or 4 years. We've tried the methadone clinics. We tried the Suboxone. What do you think about those treatments?
What's his age?
He's 30 now.
Jim?
Yeah. We run a pretty large Suboxone clinic at West Virginia University, it's Chestnut Ridge Center. Before Suboxone came around, Suboxone's been around.
Just a minute. Tell us what Suboxone and methadone are. A lot of people may not know what those are.
Okay. So Suboxone is a partial opiate medicine. Okay? Methadone is a full opiate medicine. Methadone is a very similar medicine to other full opiate medicines such as OxyContin, Percocet, Lortabs, or even heroin or morphine or codeine. Okay? The way I usually describe it to patients is that your brain has certain doors that these medications are working on. The full opiate medicines open these doors all the way, let in the chemicals to make you feel good, take away pain, this sort of thing. There's other medications that we have that are called opiate blockers that work on these doors by shutting those doors, okay, and they won't let in any of the chemicals. What Suboxone is, it's a partial opiate medicine. It opens the door, but just cracks it open. So it lets in some of the chemicals to keep people from going through withdrawal, and most importantly, which is what many of these medications do as far as from addiction treatment standpoint, is to keep people from craving. Okay, and that's what Suboxone does. Now, Suboxone and Methadone are the two medications that are approved for opioid addiction treatment. It is very important that this is done and prescribed in the right way, and that means that they get the necessary psychosocial treatment, the counseling, that they get recommended and required to go to 12-step programs such as Narcotics Anonymous or Alcoholics Anonymous. But I have a very low opinion of people just prescribing Suboxone or Methadone without all of these other necessary steps in place.
So is it kind of like quitting smoking? If Patty's son has tried once and failed, does he still have a chance to go back and try again?
Absolutely. Addiction needs to be seen as the reality that is a chronic relapsing condition. And so when people are relapsing, it should be considered normal. And what needs to happen is they need to learn from their relapses, and then how can they change behavior, what kind of treatment needs to be adjusted to keep them in treatment and then keep them well.
Ongoing process. Interesting.
Yes.
Carol from Cabell County, ask us your question, please.
Yes, I've got rheumatoid arthritis real bad, and I've been taking hydrocodone and prednisone, and there's days that I have to take maybe one more than I usually do because I hurt worse, especially if it's cold or rainy.
Sure.
And I have to use a cane sometimes. And I was wondering if, with the new laws and everything, would it be hard? Is it going to be hard for me to get my medicine?
You know, I don't think any of us can answer that for sure because we don't know what the new laws are going to be. But the new laws are designed to try and help people get the medicine they need and keep people who are not supposed to have it from getting it. So the new laws are hopefully not going to do anything to impair you getting your medicine, but it sounds like you're taking a very reasonable amount of medication, and I can't imagine that anybody would purposely do anything to keep you from getting that type of medicine that you need. Neither one of you heard anything that would be contrary to that, have you?
No, obviously, Joe, it just tells us that we need to get in the ball game starting tomorrow morning and see what these laws are, and that's she has a reasonable fear, and we want people to get the medicine they need, and we just don't want it on the playgrounds and out on the street where it shouldn't be. And so we'll be making some phone calls in the morning trying to straighten this out.
All right, well, thanks. I know that's something that Rick is particularly interested in, is making sure that people who need their medicine can get it. At the same time, we're trying to keep it out of the hands of the people who shouldn't have it. And so that's something we'll be watching closely, but nobody knows how it's going to end up just yet. I'm very interested in what you were telling us about this being an ongoing thing, though. Mm-hmm. So it's ongoing if you're going to try and avoid or become abstinent and stay away from narcotics. If you're an addict, you're going to try and get off. And it's ongoing if you're under chronic pain management too. I mean, this is a maintenance issue either way. Is that right, guys? I mean,
yeah, that's fair.
Is there any red flag that you see that makes you take one of your patients who's on chronic narcotic maintenance and say, you need to go see my buddy Jim and get off of the narcotics and get into his 12-step program? What makes that trigger for you?
Well, there are a number of red flags. For example, if someone uses an illegal substance or obtains their medication from the street as well as from the physician, that's a red flag. If the person doesn't have the medication in their urine when they should, that's a red flag. If you're giving them prescriptions and you can find out through the West Virginia Board of Pharmacy those prescriptions are being filled and yet they don't show up in the system, then those drugs are going somewhere but not to the correct area. That's a red flag. Those are the big ones. And, you know, of course, the other thing would be to find the prescribed drug not there and an illicit drug there. Then the assumption is that the currency for the illicit drug is the legal drug, and that's bad.
Actually bartering it. Gotcha. We have James on the line from Cabell County. James, what's your question for us, please?
Well, I'm 57 years old, and I've got permanent back injury. And the doctor I go to now does not believe in any kind of pain medication. And the pain's got so it's unbearable. Is there any course of action that I can use over the counter? I was going to a pain clinic, and they had me on Feldene, Lortab, but due to illness, I couldn't go back. My wife became ill, and I had to just quit. And I really need help.
All right, I'm gonna let Rick take this since it's a pain clinic. This is a gentleman who has been in the pain clinic and is now out of it. What can he do? What should he do from here?
Well, he's in a tough situation because of social issues with his wife. It sounds to me like he was on a pretty good regimen before, and as soon as possible, I'd recommend he get back to that regimen or get to a pain clinic closer to his home. Unfortunately, in this state, we don't have a lot of medical resources available in the rural areas, and so people suffer needlessly, unfortunately.
Interesting. It's a tough line to walk for sure. We certainly wish James good luck in finding somebody to help him, but maybe you can try a different pain clinic if for some reason he's ruined the relationship with the prior one. The next call is from Jim in Kanawha County. Jim, ask us your question, please.
Yes, sir. I broke my back in '85, and I've been on hydrocodone for ever since. And I re-injured myself 2 years ago, and since then, since that time, I've been retired from UMWA medically, and now my medicine just don't work anymore. I take it constantly. Sometimes I'll go 2 or 3 days without sleep, and it's just a constant battle with this back pain since I re-injured it 2 years ago. And now I got to go to a pain management clinic. I go to the 10th, and I just want to know what that questions I should ask and what medications I should ask for. Or, I mean, like I said, I'm in the dark here, and I just like to have some information. I go with this.
Thank you for that question. That's a really interesting question. So Jim's going to the pain clinic for the first time, and he has a serious problem. He wants to be taken seriously. How should he approach it? What should he tell his doctor? And should he ask for something specific, or should he just say, "Here I am, take care of me"?
Yeah, I think you show up and you be honest with the physician, give him your true history and what bothers you and what you've tried that's worked and what you've tried that hasn't worked, and then he'll give you an opinion. I usually like to give a series of potential treatments, and then the patient selects the one that they seem or that they think they could be most compliant with, and go from there.
Well, good luck, Jim. I hope you get what you need. I'm going to turn the question around I asked earlier. We only have about a minute and a half left. But is there ever anybody that you see that comes to you for detox or for addiction that you think really has legitimate pain and should be on a chronic pain management regimen, and turn around and send them to somebody like Rick and say, you know what, you don't need to try and get off of this. You need to get on a regular, steady state level of it and be treated with this ongoing. Do you see that?
Yeah, that is a question. That is something that we do see, and every now and then we will send folks over to Rick to get them treated. If somebody indeed has an addiction, however, prescribing long-term chronic controlled substances such as opiates would be contraindicated, so that's not something we would look at. Now, at the same time, that doesn't mean their pain cannot be treated, for there's certainly other ways to treat their pain besides the chronic opiate treatment. And then we're able to send them over to Rick, and they're able to do a lot of the other assessments and get a really good plan in place to help these folks, and so they're not suffering as much as they used to be.
We've only got a few seconds, but I have something I was taught, and I'm curious if it's correct. I was told if you take pain medicine only when you're in pain, that you won't become addicted and could quit after a year even of taking it, as long as the pain were withdrawn. But that if you take it to preempt pain that hasn't yet occurred, that predisposes you to addiction. Is that a reasonable theory, or is that bogus?
It's really not a reasonable theory, and there's certainly needs to be a clarification between what is meant by addiction and what is meant by dependence. For just because of the nature of these medicines, if somebody is on these medicines long enough, they will become dependent. But that's the case for a number of antidepressants and some antihypertensives as well. That doesn't necessarily mean that somebody has gotten an addiction. Usually about 10% of the patients that in America will have an addiction issue, and it's those 10% of patients who will become addicted to these medications.
We have to say goodbye. I wish we could stay longer, but we've been talking about prescription drug abuse with Dr. Rick Vaglienti and Dr. James Barry. Thank you both for being with us. If you'd like more information, see your family doctor. If you need help for yourself or a family member, call the Prescription Drug Abuse Quit line at 1-866-WV-QUITT or visit the website at www.wvrxabuse.org. For Doctors on Call, I'm Dr. Joe Prudhomme. Good night and good health.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.